As you probably know, the diagnostic system in psychiatry is based on the DSM. The DSM is a descriptive diagnostic system, and it is not brain-related. Recently there is an attempt to try and find the underlying causes of mental disorders, which will allow in the future to have a brain-related diagnostic system. In the last few years, I'm trying to create a comprehensive framework, theoretical framework, in order to relate mental disorders to their underlying brain origins. And I call it clinical brain profiling. And it is detailed in a book titled Neuroanalysis. And also you can find it on the web if you go to the website titled Neuroanalysis and to the pages related to clinical brain profiling or brain profiling, then you can find a systematic attempt to generate a testable prediction to a wide spectrum of mental disorders. Here I want to talk a little bit about the practical, concrete way that you can use this let's say diagnostic proposal. You can also find it in a more detailed formulation in a paper in Medical Hypothesis titled Neuroscientific Psychiatric Diagnosis that I'm holding here, and you can also find it on the web, where there is an Excel program that you can download and actually use in order to generate the prediction. Clinical brain profiling is formulated in using a translational matrix. It is a matrix, it is a simple matrix where the input is comprised of signs and symptoms, and also clinical history of the patient. This part of clinical brain profiling is actually based on a currently descriptive system. It is very similar to the DSM. In this sense, clinical brain profiling proposes an evolutionary process where we start out with the current diagnostic system, and actually much of this part is taken from the DSM and from scales, consensual scales. Once inputted into the matrix, sets of signs and symptoms and history information are clustered or classified to a presumed brain disturbance. For example, if the patient has high scores on loosening of association, delusions, and so on, then he will have the translational matrix assign high levels rating to disconnection dynamics. For example, if the patient has more scores and findings, clinical findings of negative symptoms like poverty of thought, constriction of affect, and so on, then the translational matrix will assign higher ratings to parameters that relate to overconnectivity dynamics. So on one side, the translational matrix inputs signs, symptoms, and clinical information, and in the other side it outputs a set of parameters indicating what will be the presumed disturbance in the brain of the specific patients that you are rating. So it actually generates a vector where all patients can be rated on a three-dimension brain perturbation dynamics, specifically neural complexity, matching complexity, and disturbance to the basic configuration of internal representations, what is recently known to be probably the default network. These three parameters can be broken down into further parameters, thus generating a vector of many items. For example, neural complexity would be imbalance between overconnectivity and disconnectivity dynamics, like exemplified just a moment ago. So actually, you instead of neural complexity, you can actually rate the patient on overconnectivity dynamics and disconnectivity dynamics. Matching complexity relates to the way, to the extent that internal representation are optimized by incoming input, by incoming experience. And if they match, then you have an optimization dynamics. If they don't match, you have a de-optimization dynamics. So actually, matching complexity relates to neural resilience, and this can be broken down into two types: optimization dynamics and de-optimization dynamics. Connectivity interrelations in the network could be frustrated in the sense that the numerical or excitational parameters between neurons don't match their optimal interactivity. This is a little bit more complex. You have to read about it more in the book. And this could create a frustration dynamics in the network, actually perturbating the network and destabilizing it in a sense that is minor than optimization and de-optimization dynamics, and this is probably presumed to emerge as anxiety. So actually, you can use the clinical brain profiling in order to generate a profile that predicts brain disturbances to a wide, comprehensive set of clinical symptoms, thus offering two very important things. First, a taxonomy, a nomenclature that will radically change the diagnostic approach. Instead of having a description like psychosis, depression, anxiety, you'll actually generate a brain-related language, a brain-related taxonomy that is like in other fields of medicine. It's a pathological system, and this in itself has an important aspect, because there is an old saying, a Chinese saying, that says wisdom begins by calling things by their correct name. So by calling mental disorders by the correct name, by their brain-related name, you actually start to a little bit to revolutionize psychiatry. But more importantly, once you start giving the correct names to mental disorders, then in research and in imaging studies, you can actually start and prove or refute clinical brain profiling. You can actually sit in front of a patient by downloading this matrix. You enter the clinical information, you get out a vector of parameters that predict what you will find in neuroimaging, and here you have it. You can actually prove or refute clinical brain profiling. So clinical brain profiling is downloadable from the web. There is a downloadable Excel matrix program that you can download and start to use with your patients.